Next talk is coming up is from Patty Musolino at MGH. She's going to be discussing microvascular correction in with genetic correction in ALD. And I just want to take another moment here to recognize Dr. Cartier's contributions to the community at large. Patty's project is going to be building on the gene therapy correction, and I just want to take another formal moment to recognize what an enormous milestone this is for our community to have a gene therapy this fall that is really, truly ours. So Patty will be building this, but one more round of applause for Dr. Cartier, who's our Ann Moser Award recipient.
So it's a pleasure to be here. Thank you for making this community exist. You guys have no idea how uncommon, unlikely it is to have a group that really finds the synergies, doesn't try to do the work that others do, and always makes room for new people and from people that are different. And one of those that is different, I don't know if you see in the background, there is a Latin American map in there. I'm originally from Argentina, trained there, did my PhD between Buenos Aires and the Karolinska Institute in Sweden, and then ended up landing in Boston. Met Dr. Eichler in 2005 in an interview, and then since then I've been working on adrenoleukodystrophy, initially looking into microglia and what we know about microglia and leukodystrophies, and then it evolved into the story. And today I want to be presenting the work that we've been doing with a very large group, and there is a lot of people to give credit. I try to put pictures as I present some of the data, and because there has been no talk about the gene therapy, I did put a little bit about the gene therapy, what the trial was about, and what are the outcomes for those of you that haven't had a chance to hear any of those presentations. I work with a lot of people. I also am leading the group that is trying to develop gene therapy for vascular leukodystrophies. And these are genes that change the vessels, and that's where I come in between. I'm a stroke and critical care child neurologist. I do pediatric and adults. This is where MGH is in Boston, for those of you that heard a lot about MGH, but where is that? And this is the buildings, and we have the luxury of having a children's hospital inside a large adult hospital, and that's why we can see babies from when they are in utero all the way to their senior years. I like this slide a lot. I started with a timeline, and then Florian populated it with the real patients. This is the most beautiful thing, and we're not going to show the women because I'm going to be concentrating on the cerebral form of the disease. And as we heard, women are not affected by that if they only have one X chromosome affected. So this is a journey of boys and babies, and thanks to newborn screening in some countries, we're now learning with them what is having ALD as a little baby. And we also know that at some point in childhood, between 4 and 9, the most common time, some of these kids are at risk of starting to have inflammation in the brain and suffer what we call cerebral ALD, the cerebral demyelination. And I have another timeline that is how this started. And here I changed the real kids and the real people for images of the brain. So you're looking at an MRI of the brain, and this is a section that is going in this direction. And this is the back of the head. This is where the eyes will be. Imagine the feet towards you. And what is black here is the normal white matter. And what is gray is where the nerve cells live. So white matter is where the connections between the nerve cells occur. If you want to think about it, the highways, small roads. And babies are born with normal brains. We know that the disease causes a mutation in ABCD1, as you guys heard Dr. Eichler early in the morning. Very long-chain fatty acids, something that you're very familiar with, accumulate. And that, we think, causes dysfunction in different types of cells in different parts of the body. But one thing we know, inflammation happens only in the brain and in the white matter. We don't have inflammation anywhere else in the body in cerebral, in ALD. So kids are developing normal, and some of them, and it's around 40% of the boys that have the mutation that could turn into developing these white patches in the white matter in the back of the brain. And that's what we call a cerebral lesion. This usually at that stage doesn't have any symptoms. And I'll put another thing that is a little bit more graphical than this. If then we have something that we call contrast enhancement, you guys heard about the consensus. If you have a lesion with contrast enhancement, then you are recommended to have a transplant. If your Lowe's score, and I'll try to touch a little bit on that, is less than 9. So contrast enhancement is that contrast that they put in the boys in the vein. And in normal conditions, which is the rest of the brain, as you can see, the contrast will come into the vessels and leave the brain. It won't stay in the brain. But if your blood-brain barrier, which is the vessel's barrier, is abnormal, then you're going to see leakage of that contrast. And that's what this rim, the kind of the butterfly sometimes described in the brain looks like. So the lesion is in here, and this is the edge where kind of the wildfire is expanding. So if you think about a wildfire, is a very good analogy because it's the pattern that the lesion takes to grow. Whatever is next is going to get affected next. And we know that if we don't do anything, most kids, not all of them, there's maybe up to 10% of the boys that can do this themselves, we don't understand how, will go on to arrest the disease, those 10%, but most of them, 90% of the boys, will go on to develop progression of that cerebral demyelination, and that causes loss of neurological function. So there is a window for rescue treatment, and I call it rescue. I wish we have a preventive treatment, guys. I wish we can say, I don't get the lesions. And this applies to the boys and to the men, because it will be great to have something that can bring that threshold back to where we can keep it for the rest of the life of the individual. So we don't have to be dealing with this much more accelerated form of the disease. And in that window, if we are able to change the bone marrow, and you heard the story about Natalie Cartier and Patrick Abro and Hugo Moser at the same time starting, this is more than 30 years ago, they transplanted boys with bone marrow transplantation as a compassionate use of a treatment that they thought could have an effect. And one of the boys had a good response, and that led to the development of using bone marrow transplant, so changing the cells, immune cells in your bones, basically, to see if you can change the inflammatory part of the disease. We're not changing, in theory, all the stuff in the brain. We're changing the way that the inflammatory cells interact with the brain. And if we do that, and this is a little schematic Dr. Eichler did it many, many years ago. So this is the vessel. The red cells are the cells that should not be getting into the brain. That's what this leakage is. The contrast enhancement is cells leaking out of the vessels with the contrast in it. And then these cells come and eat the myelin, which are these ensheathing cells, and these are the nerve cells, what are usually spare all the way until the end of the disease, and that's when we start seeing neurological dysfunction. So you guys probably have heard about Lowe's, and I don't even know if I say it correctly, and I talked to Lowe's, and I don't know if his name's Lois or Lowe's. So the Lois score or the Lowe's score. Les, thank you. Les, try to remember this. And this is a LES score, and here is, again, another patient, and you can see he's around, at this time, is 6.5, almost 7 years of age, and this is his karate practice. And I'm gonna guess that a kid around this time, this is not his MRI, because we didn't know that he had disease. The family didn't have a history of ALD. But this is a small lesion in the back. This is a low score. And these kids are primarily, when you examine them and when you look at them going around in school and everything, asymptomatic, no symptoms. In contrast, when this kid, several months later, developed initially some changes in behavior and then difficulties with ambulating, mostly from vision, and then hearing problems, and then ended up having what we know as more like the classic cerebral ALD that you also heard today in the patient panel, and how fast it can progress in some of these patients. And I put a representative MRI of that lesion. The white patch you can see is much, much larger. And that's what a Lowe's of 19 more or less looks like. And this is where we are not recommending to do bone marrow transplant. This is a very advanced disease. By the time that we get anything to work, things are already out of control, and we cannot reverse it or prevent them from dying. So I use this analogy, and forgive me if anybody takes offense about being the brain, but how do inflammatory cells, these things that come into the brain and produces the inflammatory demyelination occurs? So if you think about leukocytes, white blood cells, going into a vessel, this is a little vessel, and having to come into a tissue, they need to, first of all, slow down because they're flowing, no? They're flowing with really fast rate. They gotta get attached. Then they have to talk to the endothelium. And at the end of the day, the endothelium has to make room, open up to let the cells come in. So I use the analogy of a customs guy. So if you're going from here to Canada, and let's pretend Canada is the brain, the US is the bloodstream, and you are the leukocyte, in this case is the car, and then the endothelial cell will be the guy at customs. You can be very important, but if you forgot your passport, you're not going through. They don't let you in. Like, try it. So there is a series of interactions that need to happen between the inflammatory cell and the endothelium in the brain to allow that cell to come in. And I go back to the same point that we were talking before. No other part of the body has inflammation. So this is very unique of brain endothelium. Something is different between the inflammatory cells, the brain endothelium, and what is in the other side, which in this case we know, the myelin, which is suffering because it has a lot of lipids. And that's what gets altered when you have accumulation of very long-chain fatty acids. So there is a series of things that are happening. So if you have a normal blood-brain barrier, normal customs functioning, some cells go through, other ones get, no, you don't go, and then some cells go back out. That's what normally happens with leukocytes in the brain. They come, they monitor, patrol, and they go out again. But if you have a dysfunctional blood-brain barrier, you're stuck inside. And that's going to be you get stuck in Canada. You can't come back to the US. So this will mean that you are stuck in the brain and you're putting the brain tissue at risk of having destruction, which it happens when you have inflammation. So is this happening in ALD? And we know it from many, many years. It's in the first descriptions more than 100 years ago in the histology very plainly that there were inflammatory cells at the leading edge of that wildfire. And then we look into more the specific markers of that blood-brain barrier, the endothelial markers that show the tight junctions that they have. And we saw that there was disruption. And these are patients with cerebral ALD that have succumbed to the disease and donated their brains to the Maryland Brain Bank. And that's where we did the study. So the question was, we do see the vessels suffering and not working normally and the blood-brain barrier being more permeable. Is that specific of the endothelium being affected by the lack of ABCD1, or is it just a consequence of very angry leukocytes that are coming and affecting the endothelium? So we model this in the dish, and we basically, I'm going to show you here a little video of these white spots are white blood cells. The ones that you can barely see are the ones that are going too fast to be attached to the endothelium. The endothelium is in the back. Imagine endothelium is going to look like this, and the white blood cells will be like that. So those that you can see rolling are the ones that are having these interactions with the endothelium. They're basically exchanging passports with the endothelial cells. This is a control endothelium. Let's take ABCD1 out of the endothelium and see what happens. And this is human endothelium. And now instead of seeing a couple of cells rolling, you see a myriad of cells rolling. There's a lot more interactions. So the endothelium, when it loses the ABCD1, starts to get very sticky. So white blood cells can stuck to it, and a little bit leaky. So it allows cells to come through more easily. So we have done this at the molecular level and at the functional level and confirmed that that's the case. So in few words, we have in normal conditions, the white blood cells flow inside the vessels. The endothelium are those custom guys, are the boundary guys. And they have the role of getting all the information, but they are at the orders of other cells, which in this case are pericytes, astrocytes, of course, the inflammatory immune system of the brain is called microglia, and the neurons. And this is a crosstalk, and they're telling the endothelium, okay, give me a little bit more glucose, send this cell out, don't give me that, I need this hormone. This is all constantly happening at a very high level. But when we lose ABCD1, we now seeing that the endothelial cells with very long-chain fatty acid accumulation start to get adhesion molecules increased, and the tight junctions, which are the ones that keep them very tight and impermeable, start to open up, and then you can start seeing migration of abnormal leukocytes or leukocytes that shouldn't be in the brain. And we know that the monocytes are the primary ones. So how does this happen in real life in the brain? So this is what we call a capillary bed. So you have a little arterial and the blood is coming in. Here is like imagine it's empty. In reality, it's more like this. It's already filled and there is blood coming in from the arteries and these are the veins. And the tissue is taking what it needs. And you can see the white blood cells in between. When things start not to be normal in the interaction between the in-sheathing cells, the endothelium, and the cells inside, then you can start seeing leakage and then slowing down of the blood flow. Because if there are many, many, many white blood cells, the blood flow will be slower, will be much more sluggish. So the question is, can we study this in humans? Can we see this in the boys? And in the MRIs that we do, there is a sequence that is called perfusion imaging. And what you're seeing here is a movie of the contrast coming into the brain, flowing towards the center, and getting out of the brain. So we can see the blood flow. And the brain has two mechanisms to adjust blood flow when it needs it more. So if I'm talking right now, the left side of my temporal lobe is getting a lot of blood flow. One way is increasing the faucet, opening the faucet. And that's basically what we call cerebral blood flow. So you dilate the vessels and you get a lot of blood flow, or you get your heart to pump a little bit more, okay? Another mechanism, which is much more subtle, but is active constantly across different parts of the brain, is that your capillary bed that I showed you before is not every capillary is flowing at the same rate. Some of them are more homogeneous in flow. Some others are slower. Let's say here there is a little white blood cell traveling in this one. There is no white blood cell in that one. So this is how normal brain perfusion is. But let's say I'm really now struggling and I need more blood flow. One mechanism that the brain uses all the time, they homogenize the flow in all the capillary bed and they get more blood flow, more oxygen extraction. Because this is related to time, there is an equation, a lot of physics and mathematics. And bottom line, when things are flowing in the normal conditions and you can adjust, your brain gets what it needs. When things start to slow down and they're not able to adjust, the brain starts not getting what it needs. And then you can even have cognitive impact from this, which is like slow thinking. So you're going to see two measures that I'm going to show, like tables and charts. One is called mean transient time, which is the time that each capillary, how much the contrast was in the capillary. And then if we average this is the heterogeneity of those different capillaries and pixels. And then the other one is the constant of permeability, which is in this particular sequence called K up. Okay, so this is permeability, so the endothelium open, things coming in with contrast leakage. And this is basically the flow velocities in average in the brain. So the first thing we would study were patients with ALD that did not have cerebral disease and they were young. And we found that in the white matter, as you can see, compared to the control, they have an increase in the heterogeneity of flow. So they have some capillaries that are flowing slightly slower. I'm making things simple and don't take me literal on anything because I'm trying to transmit the message because you'll see what this means in terms of predicting disease or seeing response to treatment, which is easier to understand than this one, I think, or at least for me. And that has metabolic consequences. So the cerebral metabolic rate of oxygen is lower for those patients that have ABCD1 deficiency compared to patients that do not have ABCD1 deficiency. And the brain has multiple ways of compensating for this, and we're all walking and talking and laughing and understanding jokes. So we do have the ability to compensate for a lot of this. We do know that the areas of the brain, as I was showing you, that are more affected with the disease tend to have the higher heterogeneity of flow only on those children that have ABCD1 deficiency. This is not something that we see on control patients. So we also know that in the time of development, in that 4 to 9 years of age, we see the higher heterogeneity of that blood flow in the white matter, in the areas in the back of the brain, the splenium of the corpus callosum, where the lesions are more frequent. So there's something here about how microvessels work in the brain and how the gene defect affects them, that it's related to where the disease occurs and when the disease occurs. So another way of seeing it, which to me is a little bit easier. So here in the top row, you have the lesion. So this is the brain, and then I zoom into this area where the lesion is going to show. And this is normal white matter in black. It doesn't have a white patch. And this is the flow velocities that I was telling you, and this is the permeability constant, and this is the metabolic consequence. And here we go to the scanner every 6 months. I think In this one, I have an 18-month follow-up, so I skip a couple scans. And I don't see much in this one, but in the T2, so I don't see a patch, a white patch, which is a classic way of diagnosing cerebral ALD. But I do see a very hot spot on the heterogeneity, so things are slowing down. And the permeability of that endothelium is starting to be more leaky to the contrast. This is the gadolinium contrast that is put in the vein of the kids. And that has a metabolic consequence. And then finally, another 6 months later, we see the little patch. You see that little round circle over there? That's the lesion, the first incipient part of the lesion. This is the earliest that we can catch it. And these are boys, of course, that have been either now diagnosed by newborn screening. This boy in particular is not. This is a boy that was benefiting from having had another member in the family affected and being on screening because they tested for the very long chain fatty acids and the gene. And you can see that the permeability, when you start seeing these little lesions, is increased. And for those of you that are wondering when does this lesion catches contrast, this was at least 12 months before we saw it in the classic sequence of the contrast enhancement that I showed you at the beginning. This is a much more sensitive way of looking at blood-brain barrier disruption, the perfusion scan and the constant of permeability. So in other words, you have a lesion in the T2 lesion, the white patches, and this is the lesion in terms of perfusion dysfunction. You treat it with bone marrow, the perfusion normalizes. The lesions, unfortunately, as you know, with the bone marrow transplant, we cannot make them smaller. We just keep them where they are. And that's why we call it a rescue treatment, because it holds the disease. It doesn't get rid of whatever the disease damaged up to that point, at least with what we have in bone marrow transplant at the moment. So I'm gonna now take a little bit of a turn and introduce you to the gene therapy that got provisionally approved in September 16th by the FDA. And the story of this, as you heard today, and I'm so glad that we get to honor Natalie and Patrick, because it really comes from their work to be able to now have more than 30 years of experience of bone marrow transplant. And then finally, in 2000, this got published in 2009, but these kids at that point were 2 and 3 years out from the transplant. So this is at least 2006, 7, when the first boys were treated with gene therapy. And this was the story that Natalie was telling you just earlier today. That was taken on by Dr. Eichler, Bluebird Bio, and a group of collaborators, and it developed into the gene therapy trial where more than 55 patients were enrolled. So what is this thing of allogenic hematopoietic stem cell transplant in pictures? It means that you get a donor that has ABCD1 function normally in both the bone marrow and everywhere. Then you have the boy that is affected by the ABCD1 deficiency, the ALD. And unfortunately, we do have to make room in their bone to get the donor cells to go where they need to go. To make room in their bone for the bone marrow that is going to be received, they need to get chemotherapy. So that's not a joke. That's very... It's a tough time for the families, for the kids, because they get to be put in isolation. It depends where you are, how you fare. So that's why the recommendations, as you saw, is that to do it with an expert in bone marrow transplant, not anywhere, and ideally that has experience in ALD. And you get the donor infusion after you make room in the bone of the kids by the chemotherapy. And what we think happens is that these hematopoietic stem cells, so HSC, are traveling and engrafting in the brain as new immune cells that can now control the custom guys. That's to put it in simple words, what we think is happening. We don't have full proof of all of this. There's very anecdotal experience, and that's because, luckily, most kids that are getting transplanted and get a successful transplant are able to arrest the disease, and we don't have the brains to look at them, okay? So I'm glad that we don't have so much data on this, because it means we're doing well. So this is what the survival is on kids with early lesions, lows less than 9, that were transplanted with bone marrow transplant, a conventional allogenic. Allogenic means comes from a donor that is not you. Auto transplant, autologous means that it comes from yourself. So this is the natural survival curve of patients that were not treated with cerebral ALD versus those that got transplanted. This is what Dr. Eichler discovered many years ago, working with Richard Ransoff, that there was an area in the brain that was lacking microglia, and we think that that's how the bone cells with the stem cells become monocytes, those guys that I told you were traveling and getting into the brain, put the custom guys here, and then come into the brain and make microglia. Microglia is how we call the monocytes in the brain. But we are not sure what they are, if they're monocytes or microglia, but they're kind of the same cousin cells. So this is what we know in the survival. And if you're asking about major functional disability, the ability to see, to walk, to talk, to hear and communicate verbally, the patients that get transplanted do much better than those that do not get transplanted. So that's what we use to measure the success or not of another therapeutics in ALD. It's always going to be to how much neurological function these boys are losing or not if they are under treatment. So we have a lot of risk and limitations on allogeneic transplant. I think I'm going to go a little bit deeper about one particular limitation, which is the ability to find a donor, which I think is important to touch. And these are courtesy of Dr. Christine Duncan, which is a transplant expert at Boston Children's. And the allogenic transplant has a significant risk of mortality. There is something that is called graft failure. So you just heard it this morning that Alex, the first transplant, didn't work. You put it and they don't go and they don't home. You did everything that you needed to do, but for some reasons that were difficult to control, you don't get the chance to engraftment. And then there's something called graft versus host disease, which means the cells of the donor attack your body. And that can attack the lungs, the liver, and the lungs and the skin. And that could be something pretty serious, life-threatening, and also require a lot of immunosuppression for a long time. So there are consequences of having to receive a transplant. There are treatments, they're manageable. Most kids do really well with this and things get better and the disease stops. And then doing a related versus an unrelated donor also makes a difference. And that's why we always hope that there is a related donor, because you have less chances of this attack by the graft. But I think this is one of the most important limitations. If you can see the possibilities of finding a donor depending on what race you fall into, it's very encouraging if you're white Caucasian. It's really not good if you're Asian, Native American, or Latino, or African American, okay? And just to put it in simple words, less than 15% of the boys with CALD find a really good donor match. And Dr. Troy can talk a lot more about being able to do really well with transplant even when you don't have a perfect match. You should always go to an ALD expert bone marrow transplant person to determine if you have or not a donor. So I'm not gonna put this as the limitation. Please ask the experts. But I think it's part of what it then becomes complications, no? The less ideal the donor match, the more the drugs and the complications that you could experience. So as Natalie was saying, and Patrick, you saw it in the video, there are kids that don't have a donor, that were not able to be offered any treatments, and that's where these, let's take their cells out, that's why we call it autologous, is their own. There are CD34 cells that are the hematopoietic stem cells. Then we put them in a dish. We grab a virus that is called a lentid and brings the ABCD1 gene inside the cells. We are still in the dish. And then we have to do the chemotherapy for the same reason, make room in the bones so these cells can engraft. We bring the donor cells, now their own cells, corrected, and we expect the same thing, that they travel into the brain, get through the customs, and make microglia, and stop the disease. And that's what the study did, and these were the centers that were enrolling the patients. And I want to say there were like 12 cerebral ALD boys being seen at MGH in a single year at that time. This is more than 13 years ago. The moment this study came up, in less than 12 months, we screened 184 patients from all over the world. So it affects all of us. You can see the countries. There's no one spare, and there are probably the difficulties of reaching information that are making people not get to the treatments. There are many other reasons. But in a study where the sponsor is able to bring patients to wherever the study is being executed, is not so much the ability to pay, is the ability to understand and access that even there is a study, that you could choose to participate as a patient. And this is basically the number of patients that there were 2 consecutive studies, and the number of patients that were responding to the gene therapy is very, very positive. I like this picture a lot because as I was telling you, the lesions that start in the back. These kids had, in general, early lesions, and you can see what happened a year later and 2 years later. And you saw in my first picture in the timeline what happens at 2 or 3 years if you don't treat. This will be more like this. So this is what happens with the lesion. If you're talking about the blood-brain barrier and that leakiness, the leakiness, which is a contrast enhancement, is a different sequence, is going away, and we don't see that expanding like the wildfire as we used to. So this is the results of the gene therapy. These are all the patients up to March 2021, and you can see the lowest, I should remember, this was just 5 minutes ago, less score that were kept primarily where they were after a small slope of increase, as you can see, as the therapy takes its time to work. And there are some patients that were in higher low scores. Those patients also were able to maintain the low scores. So the therapy show a similar efficacy to bone marrow transplant. So autologous and allogenic correction of stem cells can halt cerebral disease. That will be my conclusion here. This is what we focus on working in the research side, and this is under review and Nature Communications. Apparently it moved now from one place to another one, and I'm supposed to go to my email now and see if they accepted it or not. So it's just, Anne Lauer is a neuroradiologist at Heidelberg, former postdoc, and he just texted me that the reviewers are out, like literally when I was standing here. So we looked at this perfusion imaging and tried to understand as much as we could in much more granular way what is happening to the blood-brain barrier, to the microvessels in the white matter of the brain of these kids. And you can see the picture of a pre-transplant or pre-gene therapy, and then the lesion evolving 1 year, but very little growth, and then 2 years. And I want to point this out. There is still unexpected growth in the brain lesions. Don't despair if this is happening when you're going through this, because this is expected until the lesion halts. And we saw that this is before and 30 days and 6 months and 1 year and 2 years here. And you can see how the lesions, the velocity of growth, which is, if you want to average it, this black line, pretty much flattens after you do the gene therapy in these patients. And this is a small cohort of 15 patients of the first 17 that we treated at MGH that we were able to analyze with a lot of detail. And this is comparing it to bone marrow transplant. So in blue, gene therapy. In red, bone marrow transplant. It's pretty similar. The deceleration in bone marrow transplant, we don't have the 30 days, and the scheduled MRIs are not as regulated as in the trial, but you see the same, the slope, the speed of growth of those lesions is decelerating. And then this is the vector copy number, the number of copies of that gene that we put into the cells in the drug product. So what we gave the boys is in green here, and then at 30, 24, and you can see over time. I think this is 24 months. And you can see that it's comparable at 30 days, and there is a little bit decline, but the overall average is stable over time. And we did see a dose response, if you want, curve. So the vector copy number at the beginning correlated with the faster deceleration of the lesion growth. And in fact, when you plot it in a relationship, you can see that it was somewhere around 0.6, 0.7, that the vector copy number turns into a more efficacious. And in fact, this happened in the middle of the study, and it went to a hold, and then they tried to improve the therapeutic and make the cells get this 0.7 and above vector copy number. We had very preliminary data at the time. Now we have more conclusive data that this may be important. So to make the therapy as efficacious as possible for the boys. All boys had to have contrast, that's a red dot, to get enrolled in the trial. 30 days later, some of them lost it, most of them still have it. And then you can see what happened at 6 months. Most of them lost that contrast. So the blood-brain barrier was restored. And we saw a lot of them doing this little flashy thing, but very different over time. And overall, the longer you follow them, most of them remain without any other leakage that we could see on the MRIs. So now we have, and I told you, a much more sensitive way of looking at that. So this is the cohort of patients we were studying in this study. And you can see that some of them lost the contrast, a lot of them at 6 months. But truly speaking, when we look at that constant of permeability, which is this line over here, and you can see one that is a slow responder, has a lot of leakiness still, and versus one that is a fast responder, which very quickly goes from red to green in their constant permeability. So this is a very good predictor of response. And the important thing, it didn't matter if we have contrast or not in the T1, the constant permeability in the lesion itself was the same. So it's telling us that the blood-brain barrier was kind of restored. And if you wanted compared to what about a patient with ABCD1 deficiency, an ALD patient without cerebral disease, you kind of bring back to normal for them the blood-brain barrier permeability, both with gene therapy and bone marrow transplant. And this is important. Patients that, remember those small number of patients that I told you that can do it by themselves without transplant? This is self-arrested. And they also have much lower levels of constant permeability. Maybe something to look at when we are looking at MRIs and making the decision, do we wait a little bit? Do we wait a little bit? Maybe we have this data available to the clinicians, which is not currently, okay? This is research. That hasn't yet become something that they can just click a button and get a number. And we're hoping to develop the software that can do that. That may change the way that you manage those patients. And this is, again, this constant permeability and the integrity of the white matter are correlating inversely. So the better your constant permeability, the more likely you are to respond to the treatment and to show white matter improvement. Very importantly, the entire white matter showed improved microvascular circulation. And this, I think, is the first time that we can show this is not where the lesions are. This is all the way in the front of the brain. And you can see both how the perfusion, permeability, and that constant of velocities and something called vortex, which is how the capillaries look awesome, is basically getting not even to the hemizygotes. These are the patients with ALD, without cerebral ALD, but ALD, but they're getting really close to controls, to people that do not have the deficiency of ABCD1, for both vortex area and for this parameter here, which is the RTH, the CTH, the velocity of flow. And this is staying over time. So this is a constant of permeability. You can see before the treatment, it normalizes and it continues to go down and it stays down. The vortex area, the higher the better, and in fact, they do better than the hemizygotes, which are the ALD without cerebral disease. They get very close to control values, as I was showing you. And this happens in the lesion and in areas way, way farther away. And this is to the point of, are the cells only getting in where the lesion has leakage and the blood-brain barrier is all open and there is no custom guys? Or is this really affecting all the vessels in the brain? And I think our data shows what you're doing with the bone marrow when you change it is making microvascular flow in the entire brain be better, which is good news when you want to think fast, because you need these things to adjust very quickly. And here again, these kind of perfusion, capillary integrity markers also correlating with the speed of deceleration of the lesions. We did not find the amount of CD14, these are the monocytes that were corrected, or the vector copy number in the CD14 cells, correlating with the lesion deceleration. So it's not a number of cells of the amount of gene correction in those cells that correlates, but something else. and this basically shows here the number of CD34 cells that were pretty much stable across time, and then the vector copy number of those. We then, and this was hard, this was during COVID, and this was in response to the reviewers. Sorry. and we took the cells from some of the boys that had the gene therapy before and after. And these are cells that were corrected. So if I take cells from you and I take the CD34, they can also give origin to endothelium, the custom guys, and something called pericytes, which are next to them. And interestingly enough, when we derive endothelium from these cells, which are these looking cells like here, all of them were expressing ABCD1. So these corrected cells, even though they're a fraction in the blood, are the most successful or deriving endothelial cells, at least in vitro. And this was a patient that had a transplant, that got engraftment, and 18 months later, die from a consequence or a complication. And you can see, and this is the gray matter and the white matter vessels. This is a control, and you can see ABCD1 expression in endothelium, a lot more in pericytes. That's known. These guys hanging in the forces are pericytes. This is a patient with cerebral ALD, where you cannot see ABCD1 expression across the vessels. And this is the patient that received allogenic stem cell transplantation. And you can see a lot of ABCD1 and perivascular cells, which we think are monocytes or microglia. And in these guys, which are pericytes. And here's the first proof that we are also changing the microvasculature. And importantly enough, these are gray matter. So they're not in the lesion. They're very far away, and they're getting cells that are corrected with the ABCD1 gene. So these are the conclusions. The autologous gene therapy has similar efficiency to the allogenic. It has other complications that I didn't go into, but we should discuss at some point. And hematopoietic stem cell transplant provide long-term whole white matter, microvascular, and blood-brain barrier function improvement. And then I think we have here the first clue that we are also correcting not only monocytes and microglia, but also perivascular cells, including endothelium and pericytes. I will emphasize that the geographic and socioeconomic disparities must be addressed. This is not accessible, even bone marrow transplant, to most of the world. And I'm glad that we have the ability to talk about best of care, but I also could continue to work until we have a treatment that either can prevent the lesions or slow them down so they get a shot at how the bone marrow transplants are done in their areas. And that's why we're working with Minorex on developing therapeutics that could hopefully slow down the disease progression. This work was when the lab had all these people, and this includes Alex Lenay, who helped us with some of the omics processing. But you can see it takes a villa, it takes multiple institutions. This is a group in Denmark, this is Heidelberg, and Moser, of course. And then we don't do anything without the mentors that help us with the vessels and how the endothelial works, imaging, and of course, ALD, Dr. Eichler. Thank you so much. I will always say, there is only successful trials if there is an active patient community. So keep going. That's my, thank you.